I really want to just mostly let Laura introduce herself. She's at Google Research.
But just thank you all for coming tonight. I'm really excited to see you all here. And, thanks for inviting me to give a talk. I'm Laura Vardoulakis. I am a researcher at Google Research. And I will talk a little bit about what we do at Google Research. And I'm going to give, I think it's 5 mini talks with some case studies of various research efforts that we've done. It's going to be a little bit about health, a little bit about some other things. And so if, sometimes it's hard at the end to remember like, oh yeah, in that second example, I had a question. So if you please, I'll pause after each one. If folks have questions about them, you can ask. And we'll leave plenty of time for questions at the end as well.
And I saw somewhere in your statements that there's something about AI.
Something about AI, yes. So tonight we're going to talk about a challenge I suspect almost everyone in the room has encountered or is actively trying to solve, which is how do we make AI that works and benefits people in the real world? And as an HSAC community, we know, when a model performs flawlessly in the lab, that doesn't always automatically translate to value or safety or utility for the people who end up using it in their everyday lives. So tonight I'm going to talk about how my collaborators and I at Google Research attempt to bridge that gap by really applying human-centered socio-technical considerations to the research that we do. But before I do get into our research, I do want to say benchmarks are really essential. These standardized kind of performance metrics, lab-based evaluations, they're really important and they're kind of operate as a compass. They can tell us if a model's learning, if it's improving, where the technical boundaries lie. And there are many AI benchmarks that people are optimizing for right now, whether it's factuality or medical and health knowledge or mathematical knowledge. Plenty of leaderboards out there. And these benchmarks generally represent well-controlled experiments. They define the model's technical performance under, ideal conditions. They usually represent these clean, kind of frictionless, ideal state universe. But the world in which we live in is actually full of friction. So quick show of hands, maybe. How many people here have built a system, AI or otherwise, that it performed well on paper? Maybe you had some emails, maybe you had some benchmarks, everything works great. Maybe you even had lab-based user research, everything's looking great. You release it into the wild or you launch your system and all of a sudden, there's some issues with performance or maybe some friction or some user frustration. Anyone ever experience that? Yes. So we know that benchmarks just don't tell the full story when it comes to AI performance. And there are so many other considerations to make when it comes to determining whether an AI is working well or not. Considerations like various user groups, cultural considerations, institutional structures, environmental considerations for where it's being used. So as the more and more we start thinking about those types of things, the more we start getting into taking a socio-technical approach where we're not evaluating the technology, as an isolated tool, but instead is part of a complex, interconnected system. And this framework's been around for a very long time. When you read some of the original work from the 50s and 60s and 70s, it's really striking how relevant it still is today. And so at Google Research, which is the R&D arm of the company, our goal is really to drive scientific and technical breakthroughs that's going to benefit the world, advance the scientific community, and power Google's products. So when we're thinking about research, we're often considering not just the technology itself, but the people who are going to be using it, whether that's users or stakeholders, communities, various workflows involved, how the information is flowing through the system, and the environment with which it's being used. So I'm going to share a few case studies from our work, how we do this in various ways, depending upon the research problem. Many of these are health related. That's a big portion of the work that I do, but I'll get into some others as well. And all the work that I'm talking about today has many, many people behind it. So many current and former collaborators, including Lauren, who's here. So if you have like questions or concerns about the work, I will be happy to answer them. If you have kudos about the work, I'll be happy to point you to the people who did a lot of this work. It takes a lot of people to do research like this. So I just want to thank them. I am happy to be here as their representative. Okay, let's dive in. So the first project that I'm going to talk about is AI for the detection of diabetic retinopathy. This was a one that Lauren and I collaborated on. And this paper was published at BayCHI in 2020. And so today, we have a lot of advancements when it comes to medication like GLP-1s, which are absolutely incredible. And even with that, diabetes remains a large problem across the globe. With diabetes comes complications, including diabetic retinopathy, which we'll refer to as DR. And DR is a condition caused by chronically high blood sugar. It damages the blood vessels in the retina, that thin layer at the back of the eye that's responsible for sensing light. And these blood vessels can leak or hemorrhage, and it can cause vision distortion or vision loss. And diabetic retinopathy is one of the leading causes of vision impairment across the world, and causes 5% of the cases of blindness worldwide. And so in Thailand in particular, 34% of diabetic patients have low vision or blindness in one eye. And there is a problem when it comes to access to care. There's a real shortage of specialists. These specialists are very hard to get to, and it takes a long time for patients to get results from their eye screening and even determine if they need to see a specialist or not. And so a team at Google Research developed an AI model that could detect diabetic retinopathy as well as diabetic macular edema on standard fundus photographs. So these are very common photographs that you get taken when you go see the eye doctor. And this AI can make an assessment about whether or not this patient needs to be referred to a specialist for treatment. And there were multiple retrospective evaluations of this AI model where it was fed new fundus photos, and we could determine whether the patient, we also knew the diagnosis associated with those photos, so we could determine, how well that model was performing. And these evaluations showed that the system performed very well, essentially on par with a retinal specialist, which was great. And so we had a partnership with the Thailand Ministry of Health, where this AI system was deployed across 8 clinics in a prospective evaluation. So now we're seeing how well it works out in a clinical environment for real. This was a 1.5 year long study. It involved 7,600 patients. And these were patients that were coming into the clinics for their normal eye screenings. And if they participated in the study, then their fundus photos of the eye were uploaded to the AI system in order to measure the real world clinical performance of the model. And so in parallel with this prospective study, we also conducted a human-centered evaluation. We just didn't want to answer the question, does the model work, yes or no? Or how well does the model even work? We really wanted to understand all these human elements that come into play when these AI systems are just deployed in a clinical practice. You can see all the things on this nurse's desk, even while she's using the system. So what things like these are things, what do people even think about this? How does it make them feel having this system now in their clinic? How does it work in practice alongside all the other systems that are going on in the clinic while these patients are coming in and out? And so we conducted research both before and after the system was deployed for the prospective trial. We conducted interviews, observations, we looked at logs analysis and usage data from the system. And one of the first things that we learned had to do with something called gradability. So gradability refers to the ability to read an image and make an assessment. And so when a human clinician is conducting an eye screening, they have guidelines that they use to determine whether or not the photograph of the retina is clear enough for them to make an assessment about whether this patient has or doesn't have diabetic retinopathy. And so these guidelines are generally pretty standard, but they can vary a little bit between clinicians or organizations. But just like clinicians, the AI model needs to set a threshold for quality features like image blurriness or how dark the image is before it's going to make an assessment about diabetic retinopathy based on that image. So if the image is extremely blurry, just like a clinician, the AI model is going to say that's ungradable, we're not going to use it. Okay, so after the system was deployed, we noticed early on from the system logs that on average, about 20% of these images that were being uploaded couldn't be read by the model. They were being classified as ungradable. And that's very, not good. So during our on-site observations, we observed several causes for what was going on. So why was this happening? The first thing was there was a really high volume of patients being seen at these clinics, which resulted in really limited time to kind of align the patient to the camera and get a good image of the eye. So some clinics were screening 200 patients in 5 hours. It's about 90 seconds per patient to get 2 photos of the eye. And then to take a good image of the eye, the room needs to be really, really dark and the pupils need to be really, really large. And this was being affected at some locations because the screenings were taking place in brightly lit rooms. And why were the rooms brightly lit? Well, it's because there were all these other exams that were happening in the same room. There's a table over there where there's a foot exam getting done, or there are teeth exams, or there's a patient consultation. And then to make matters worse, when you take the first image of the eye, there's a huge flash. And so then it takes even longer for the eyes to come down. And so that second eye image was often being classified as ungradable. And in some clinics, there were just older cameras and they just needed some repairs.
Do both of them need to be gradable in order?
Great question. So let me pause that for a second. We'll get to it. What was really interesting was that, you can fix cameras, you can do all these things, but what happened as a result of this gradability issue is that it really had it left people with strong impressions of the system because it's not as though the conditions changed between before the AI system was deployed and after the AI system was deployed. They're the same conditions. And these nurses who are taking hundreds of photographs a day are very used to working with imperfect data. And so they also have additional data that they can use that the AI model doesn't. So they can see the patient in front of them, they can talk to them, they can get their history. And so this led people who were operating the system to have very complicated views towards it. In many ways, the system helps them a lot, and we talk about that in the paper. But when it came to gradability, it really didn't matter that the lighting conditions weren't perfect. They really expected it to work with imperfect data. So this participant says, I can read it. What's wrong with the system? And another one's like, it's good, but it is not accurate. If it's even a little obscured, the system can't grade it. And that's just not going to work, obviously, for folks using it in an environment like this. So, as a result of this research, as you can imagine, cameras were repaired. Some of the simplest solutions can come from non-technical fixes, like putting a curtain or a drape over someone as they're getting the eye images taken. And then naturally, there were continued model improvements. to be able to handle less and less perfect data. And actually, since this research has taken place, there's been over 1 million AI-powered eye exams using this system, and it's scaling to 6 million over the next few years with some partnerships across India and Thailand and Australia. Okay, so that is the first case study. So I can answer a couple. Yes. So it depends is the answer. Generally,
Say the question again.
the question is, do you need to have 2 perfect images of the eye? And ideally, yes, you should. But the nurses, for example, were used to having to make judgment calls. If they got one good image and not another image, they could use all this additional data to say, okay, do I really feel like I need to send this person to a specialist or not? Whereas the AI model had very strict, it was being evaluated in a prospective trial, so it had a protocol that it had to follow, which involved 2 good images.
Did you ever follow up on patient trust with the AI after some problems have been fixed, like the patient's perception on the AI now that the problems have been?
Great question. So in this study, we did not evaluate the patient's perspective of the system at all. It was only the clinician's perspective of the system.
Okay.
Yes.
Do you think that the patient's perspective matters to how well this AI is adopted in clinics, like if patients trust it or not? Or
Yeah, it's a complicated actually answer because oftentimes patients don't have a choice. And that's happening more and more. But yes, in this system, we did not explore that question.
In this country anyway, you always have a choice as a patient, whether to be treated, whether to be evaluated. And I guess 3 questions. First, you said 34% in Thailand. I'd be interested in what that compares to in the United States. Second question is, in collaboration with humans, many times people do better when they feel like they are valued. Let's call them the nurse. And I'm wondering how you feel about, or whether you tested out them evaluating it and kind of partnering with this system as opposed to delegating. And I think that's a big topic for all AI systems, probably.
Yeah, so something that was really interesting about this research is that these eye screenings are conducted via nurses, and there's a huge volume of patients that they're dealing with every single day. And they have, over the years, kind of become specialists. They're very familiar with who has diabetic retinopathy or not. Are they qualified and allowed to make that determination? No, they are not. And so one of the things that was incredibly empowering for these nurses who were using the system is that they would almost use it to test their knowledge. And so they had a very strong idea. They can tell right away from looking at a very imperfect image whether or not this patient has diabetic retinopathy. And now all of a sudden they have a tool that tells them more information about whether they should believe. And we would get, there's some very, I encourage you to go read the paper. There are some very interesting themes there around how, we weren't ever really believed before. They never believed us. We'd have to call the doctor and we'd have to get them to make this referral. And we know, but they never believe us. And now it's like, they're going to believe us. And so there's all sorts of interesting dynamics that come into play when it's brought into a complicated system like this. And so by understanding how that system works, it really matters when it comes to its how it's going to be used and perceived by all sorts of different players in the end.
I guess I had one last question there, which is in terms of, it seems like it's bad, by the time I'm getting that picture taken of my retinopathy, what was supposed to happen before that? So I didn't get it. And do we have, any way to give feedback? Is this part of any system that could help reduce the amount of retinopathy as opposed to.
For like diabetes management.
Instead of detecting it, we might want to reduce it.
Yeah. So that wasn't a part of this research at all, but naturally, yes, AI could be applied in all sorts of ways when it comes to patient management, self-management, or management with their physician. Yeah.
We follow up to one of the previous questions. So like after you get some results back, and I'm just wondering about the follow through. So like what happens after you find out, and it's kind of related to the trust thing that was brought up. Like, is there any aspect of the way that the nurses or practitioners are meant to make recommendations to either send this person to one specialist or a different specialist or different qualities of specialists, or what? I mean, I presume they know who the leads would be, but does the trust level of the system, like, do they go, oh, I think this particular one wasn't, like this, I don't trust the system right now, so I'm going to send, but I personally read this as likely to have an issue, so I'm going to send it to my favorite practitioner versus, yes.
Definitely. So this was, again, all done within the confines of a clinical trial. So there are guidelines around how this was used and evaluated. How it was working before the system was patients would have these screening days at a clinic. There would be a huge volume of patients screened. This person, you're clear, you're good. At this point, the patients aren't there anymore. They're not in the hospital. And so now you have to go track down this person. You hope that even if they need a referral, there's no real guarantee you're going to connect with them again and get them that referral. That's one thing. The other thing is that a referral to a specialist at some of these locations can take an entire day, 6+ days wages cost to even then get assessed. So there's all sorts of considerations around, like, do I want to just, like, it's on the border? Do I want to send this patient? Do I not? Many considerations on this. So for this prospective trial, the kind of change was you got right there a decision about whether you should see a specialist or not.
And do you find that the people who are recommending the specialist would potentially have more confidence in recommending a specialist because they have the confirmation of there's a system that's also saying that my suspicion that there's something might be here is true? Or
yeah, I mean, it's not exactly because it's on par with what a clinician would assess, and so they generally don't doubt their assessments. But there were considerations definitely that came into play when it's like, oh, I have to follow this trial and this protocol. Okay, we have this ungradable image and the protocol says all ungradable images need to be referred. I know that this person shouldn't be referred. Do I have to require them to spend an entire day and all these wages to, like, get referred? So many things that this research also uncovered that then led to some modifications for even the protocol for how this thing should be evaluated. And because if you don't take those into consideration, you're going to have a very long clinical trial with a lot of pain.
Okay, so you probably want to get on to your next case.
We can go to the next one. Yes. Okay. Next example I'm going to talk about is AI for medical records. And this was research led primarily by Meredith Schreier, and there's publication at JMIR Human Factors last year. So I encourage you to check that out. When we think of medical records, we often think of them as electronic. They should be easily shareable, accessible by clinicians whenever they need them. That still is not yet the case. There are some hospitals that I've been to very nearby where even the emergency department EHR does not speak to the main hospital EHR. And so if you get admitted to the hospital from the ED, they're like literally faxing records across the street. It's pretty wild. And it's also really amazing how much data when it comes to medical records just gets PDF'd and then like set aside and forgotten somewhere, and it's completely inaccessible. So a great use of AI is for searching and summarizing things. This is true for consumers, and it's also true for clinicians. Both searching health data and summarizing health data can be really important tasks for doctors when they're trying to understand a patient's health history, and really important information that may guide treatment decisions. And so the searching and summarization features are things that we have built. These are available to cloud healthcare customers, where cloud customers can create kind of their own bespoke applications in order to search and summarize their data. But we really wanted to work with a partner to determine, okay, if these systems are available to clinicians, how does that work in clinical practice? Does it help them? Do they think it improves patient care? Do they think it impedes? What goes on? So we worked with Meditech, which is the third largest EHR vendor in the United States. They integrated search and summarization features into their EHR, and they deployed this at a medical center in Wisconsin. And over the course of 5 months, we worked with their clinicians there, both before and after they got access to these AI features. We interviewed them, we conducted on-site observations to see how this really worked in practice and what it meant for them. And short answer is clinicians found these tools very, very useful. When we asked how they thought their use of these tools had impacted patient care, saving time is really big. And saving time is like the thing that doctors care about a lot. And so that was notable, but participants also noted the impact on reducing things like waste. Like, I don't have to order this test because I know now, because I was able to find it, that it was done last month. And so that has a really big impact on care. They also noted that it can reduce clinician stress, which we all love it when our doctors are less stressed. And when they're working with systems that aren't easy to use, or worse, just very frustrating to use day in, day out, that can be really, really stressful for physicians. So that was really great to see. And we went into really task-specific things that doctors do a lot with their EHRs, which is things like, I need to find a specific document from the record, like whether or not they signed this consent form, or I need to look for a specific lab result or an imaging report. And I know you can't read these tiny, tiny letters on the screen, but these are various tasks they might do. And the light purple is how helpful their EHR was in completing these tasks before they got access to the AI search and summarization features, and the dark purple is afterwards. And they reported that it helped them a lot. And this help really contributed to a lot of the perceived time savings that it gave them. And this was really across clinical roles. People found it really easy to find information fast. And kind of the main takeaways from this work, and I encourage you to check out the paper, is that evaluating the user experience in a clinical environment is feasible. And you'd be surprised at how many people think that's not feasible. You're going to be distracting our patients or our doctors, and we have to protect our doctors, and you can't be interrupting them. And these things are very simple. These are bread and butter methods that we've used for years. We're simply, having them fill out a little paper survey. Doesn't take very long. We just kind of shoulder surf them while they're working. It's not very intrusive. People were happy to sign up for interviews and talk to Meredith about their experience. And so one of the contributions of this paper is just, kind of this toolkit of, the more and more that we see AI going into the clinic, we believe, the higher the expectations are going to become for what that user experience is going to need to entail. And we're going to need to start ensuring that it's meeting that bar. And if we want to do that, we're going to have to evaluate before and after whether it's working. And so this paper includes a little bit of a program for how to do that work, and shows that it's feasible. Okay, I'll pause here for any questions about this work. Yeah.
As you know, one of the things that happens with AI systems is they create time savings, but then that time savings is consumed.
Nobody's going golfing.
Right, exactly. So what was your observation from this kind of time saving? Did they really get more time?
Yeah. So we did not, I have to acknowledge, we did not get out the stopwatch also in this. So this was perceived time savings,
So-
which is still very valuable. So this was more of a feeling measurement. Like I feel like this is just, my life is easier using this system, which is valuable in and of itself, whether or not it was actually saving them time. We didn't do any measurements like reduced clinical errors that they were making, or like actual reduced waste, like test orders and things like that.
Those measures were all perceptions of whatever.
Perceptions of the system. Yep, for sure.
I have a question. So when you parse PDFs and all the other documents, including audio recordings, which doctors use quite often,
Yes.
and it goes to some kind of a file, potentially converted to text. In medical systems, certain things, small things could be fatal.
Mm-hmm.
So what was the accuracy of all those? A human reading and interpreting that versus the AI summarizing it? What was the delta between the two?
Yeah, it's a little bit complicated because the before system sometimes didn't even have access to this data, or they wouldn't have even had access to it at all. And so before they're using this system, if you ask them to complete some of these tasks, they're looking at a set of data that's much smaller. And then after they have access to the system, because it now can search over PDFs and all of this additional data, mostly PDFs was the bonus that they got.
Were the PDFs created by coming from a digital platform? Somebody typed it and then it created a PDF, or handwritten things scanned?
So these were like archived records from 5 years previously and earlier. So at some points, oftentimes EHR systems will just like checkpoint their system and they're like, we're upgrading everything before 2017 is now been like PDF'd and on a G drive somewhere.
Were they scanned PDFs, like handwritten stuff?
No, oftentimes it's electronic stuff. It still can include oftentimes handwritten things.
Especially doctors.
Yes, exactly. Yeah. So there were many evals for the performance. I don't have those publicly available to share, but in order to get it to launch through cloud, there were many evals to show its performance, both on actually handwritten stuff and.
The other thing is not to critique whatsoever, but I saw all the pros, but I haven't seen any cons in there.
Yeah, there were some cons. You can check them out in the paper. There were cons. Yeah, there were.
Could you share some of those?
I'm gonna have to bring up the paper and look.
Whatever you remember.
Yeah, I'll have to look.
As an example, training, was there some training involved for these people to use this?
Lightweight, actually, less than you would think. So the system generally replaced their search. They had a search bar in their experience before, which was very sensitive to specific keywords. If you mistype something, if you used an abbreviation, you would get nothing back. So the training was more of the sense that, okay, the search bar has been replaced and now you can just search like you would use Google search or some other search experience. And so when they searched, they then, I should clarify too, previously the search, it was very sensitive and it was more like a navigational tool. You would see maybe some, if you're searching for a lab result and the result that was done, maybe you get some information drop in the drop down, but mostly you would be navigating to the labs tab and then it would take you right to the results. So it was more navigational in nature. Whereas now the AI-based search and summarization experience, it would take you to something like a search results page where you had results, and some of those results would just be the straight up lab result number. Some of it was very specific. Here's the answer. And some of it would be, we found this piece of data from this PDF and we found that piece of data from the lab and we're seeing this over here and we're summarizing it all together. And there would have to be grounding so they could navigate if they wanted to find the source data. But it made it much easier for them to actually find it. And it included additional data that they didn't have access to before. So it's not a very fair comparison. They could have gone to the G drive and like searched through those PDFs, but they wouldn't.
So what happened to the summary of theirs? Or is it stored someplace or?
No, it's not. It's generated every.
It comes and then poof, vanishes.
All of that information is in the record, electronically, and then if you're searching for it, it will generate that summary. Yes.
Regenerated. So for 75 cents or?
No, it's all, it's all within the record.
Here's a question.
No, I'm actually trying to get a camera over here.
Oh,
Okay,
there's also a question on Zoom.
There was a question that popped up about HIPAA concerns.
okay.
Please, yeah, well, please move on if you'd like. But if you turn on your camera, it'll be helpful to us.
Sure, let me see. I don't know if my camera is not, maybe, okay. Maybe I think I have the camera working. Okay, was there a live question or a question from the?
I know you couldn't remember specifics or any other specifics about the cons, but do you think that you can accurately represent from your own impressions whether overall the pros outweigh the cons?
Oh, for sure.
Okay.
For sure. A very positive experience for these clinicians overall, yes. And I did like papers linked there. Please go check it out. Good stuff.
If you as a researcher were curious about other things that weren't explored in this study, for example, you mentioned that you didn't study how if the new tool reduced clinical errors, is that correct? If you wanted to explore that further, would you be able to, or is it kind of just like once this project is done, you move on to the next thing and the case is closed?
I mean, for like how we generally decide how we're going to do our research, it depends. Yeah, it depends. It depends. So for the research questions we had together with Meditech and the Bluff Medical Center, we were looking at measuring the experience. So it was not scoped to evaluating, clinical error rates or anything. There are very established methods for doing that. And we absolutely could have done that if we had that goal, but our work was really around the user experience.
How do you choose who to partner with? Like, how did you choose to partner with Meditech? Is that?
Long conversation, probably out of scope for this. Yeah.
So you had a few more case studies you want to get to.
Yes. All right. The next one I want to talk about is AI for dermatology. And thank you. This was led primarily by Rory Sayers, and there was a presentation at CHI last year on this. So Google receives many skin-related queries every year. And when a skin issue occurs, the majority of people do turn to online search first, but they often have a hard time finding the information that they need. And so there was a team in Google Research that started to explore if they could apply Google's core competencies of image recognition to the world of dermatology. And indeed, they could. But one really important thing that they noticed along the way is that dermatology data sets used for training, and this is both in medical school textbooks and training for AI, they generally show dermatology conditions on light-colored skin. And so, as you can imagine, if we create an experience that only works for some people, that would be a terrible failure on our part. So to address this, we partnered with Stanford to create a program where people could voluntarily add images of their skin and their skin conditions to an open source data set. And we also sourced images from this data set from across the web, even using Google Ads, to invite people to participate in this open source data set and upload images to this data set. And this set was open source last year. It's called the Skin data set, and you can check it out on GitHub. It has over 10,000 images of recent onset dermatology conditions across a spectrum of skin tones and body parts. And the team wrote a paper describing the process they used for creating this data set using crowdsourcing, which you can imagine could go really wrong really fast. And it didn't. It was really interesting work. But okay, so now we have this data set. We have this great ability to make a classifier that works, but what happens when people experience it? Now you can take a photo of your skin, you can receive some information, like how does that land with people? Can they understand the results? Do they have more questions? How does it work in practice? What do their doctors think about it? There's all these questions around how this would actually get deployed in the world. And so Rory explored this with a functional prototype that guided people through taking some images of their skin, some questions about it, gave them some results. They could dive into those results. And he conducted a study which was mixed methods, interviews, observations, had a little bit of usability-esque related things with 110 people. And before the patients even use this app, we really wanted to understand what do they even expect to get from this app. And so, not surprisingly, people are very interested in treatment for their problem. These were all people who are about to see their dermatologist. And they're very interested in, like, how do I solve this problem? Both for the problem that they're experiencing acutely and also preventative treatments. Like, am I supposed to wear more sunscreen? Am I supposed to be washing my face more? What am I supposed to be doing to prevent these things? They also naturally wanted some possible diagnoses. Some of them wanted like the definitive diagnoses and others were not so set on that. We're fine with like a set of possible things that might be going on. They expected information around the severity of the issue. Like, do I need to see a doctor right now? Or if I don't, like when? You better tell me when I need to see a doctor. And of course, is it cancer? Like, just tell me, is it cancer or not? And then as the team observed people using this app, there were all sorts of experiential considerations that come into play. The first is that's not always really easy to take a photo of what you've got going on. So this might involve multiple players, and that's a really important design consideration. Answering all these questions, like taking a photo and then answering all these awesome questions can feel a little annoying. And when people got results back saying, oh, here are some things you might consider that could be going on, when those pictures didn't look like the picture that they took of their skin or the way the condition is showing up, that was very confusing, naturally, to people. But overall, participants were generally very satisfied with this app. And part of this research, a separate part of this research, looked at the accuracy of it. And so matching whether the systems stated conditions matched the clinician's assessment as well. And generally they did. And clinicians also found this app really helpful with having conversations with their patients. And then there are all sorts of interesting research that opens up about how you facilitate that interaction between patient and doctor. Now there's an AI potentially in the middle of it. And then lastly, the team worked really closely with the Google Lens team to really incorporate this technology into that experience. And to date, we know we helped at least one person detect skin cancer and get treatment for that. So that was really exciting for the team.
So we have an online question.
Great.
Kevin, can you unmute and ask your question? Kevin Boyd.
Sure. Yes. So, can you talk a little bit about HIPAA and the privacy implications? Were any of these studies conducted in the U.S.?
These studies were conducted in the U.S., yes.
Not the Thailand ones, but this is.
This study was conducted in the U.S., yes. And this was a user experience evaluation. So we weren't actually connecting this data to a patient's medical record. These are really important considerations that come into play, and when we have things deployed through cloud, et cetera, when we do our partnerships, we have our studies covered by an IRB that we connect together with our partnerships. So I'm not sure if there's a particular aspect of HIPAA that
I think you answered it.
Okay.
I have a question about, so efficacy is not what we're talking about.
Right.
What we're talking about is user experience. And did you consider different user experiences? And did you, see contrasts between these different user experiences? And were there ones that you would have loved to have gotten to? Because I think for our group, designing user experiences is as fun as evaluating it.
Yeah, definitely. I don't have any data for this one in particular. I'm trying to think if I do for the next ones. The next couple of ones I don't either. There were several iterations. Naturally, the design of this comes into play a lot. And even if I go back here, how like the first 3 screens, like even trying to communicate with people, okay, you're gonna have to take a picture of your skin, but we need you to not get super close, but we need you to get far close enough so we can see what's going on. The designer on this project was Anna Urshenko, and she's really talented at like going through these options with people. And so there was a lot of work even just on the onboarding aspect. And that was to create the functional prototype to evaluate this. Then when you get into play for Lens, much of the user experience comes in the results. And so how those results, the taking of the picture, there's not a lot of guidance we have. We're playing with that product. We're working within that product's constraints. And the experience comes more when you're showing these results to people. And this is not a diagnostic tool. So this is not coming back and saying like, this is your diagnosis. But it is showing you like, okay, there are all these similar images and here's what those images are. You can now work with your doctor, you do whatever you want with that information. But that's an experience that you really need to get right.
Questioner. So one of the things that doctors usually complain, the patient goes and, assess their own situation. They do the research. They trust the AI that they have, whichever platform it is. And then they start arguing with the doctor.
Yeah.
And then they lose the trust to the doctor because the AI says this and the doctor says, don't worry about it, you're fine.
Yeah.
How did this type of interaction impacted your research, if there was any?
Yeah, so in this case, we did not see that problem. And this was a few years ago. And now it's grown even more exponentially problematic. Anecdotally, I can say I've seen some physicians become happier with their patients using AI than, for example, Google search, because sometimes when folks are searching, you have to do that sense-making activity yourself, and that can be very taxing, and people can get it wrong. Yeah, I can get it wrong too. But when patients are using AI, sometimes they're coming in with a little bit more synthesized and almost the expert assessment rather than like the Reddit assessment. And so anecdotally, I'm hearing that doctors they're like, okay, great. Yes, my patient is prepared for this appointment. But this is a huge research area. And it goes the other way too, where I had definitely got an AI written message from my doctor the other day. I'm like, I know this is not your writing. And it made me feel all sorts of things. And so it's really interesting.
I was going to say, if I have a friend who literally got kicked out of the room, doctor's office, because like, if you know that much, you don't need to be here.
Wow. Yeah.
So.
Wow.
Let them go first.
So how do you account for cultural context when studying user behavior across different communities? I'm a digital anthropologist, so I focus more on the community in different cultural trends.
Maybe that's a good time to segue to this portion of the talk. Yeah, which is the community-based participatory research.
But make sure you get the questions that are here also.
Oh, I can go after.
We can also save time for questions at the end. I'm happy to stay as long as people want to ask questions. Okay, so they have 2 more research efforts.
I could comment about that very important question he asked. A decade ago or so, I was working with doctors, and when you said, people coming in with that printout of their Google search, they all went, oh, right? Because it was extra work for them, and people went off the rails in 100 ways. And what I feel is today that has changed, it's maybe continuing education for them in their mind. And I think that's an interesting, I bet there's some literature about how that change is going and whether or not that is really because it is easier for them or they just have to cope with it.
Yeah, it's a really interesting research question and how it changes just the relationship that you have with that provider.
The lines are blurry.
There's all sorts of power dimensions that
Yeah,
are shifting as well.
Is there some literature we can look up that you know about?
I'm sure there is. The other thing that's really interesting too is that I'll just say, doctors are actually using AI more. There's very advanced tools. One of them is called Open Evidence, where physicians also cannot keep up with all the research. Like, you want the latest guidelines, you didn't learn that in med school. Like, when you went, you have to keep up with all these things, and it's impossible. And so even for their own treatment guidelines, clinical guidelines, these things are evolving all the time. And there are some really wonderful AI tools now that are available for doctors. And so,
AI agents is the best. Create your AI agents, like focus on whatever your industry. For example, digital anthropology, AI, virtual spaces. Doctors use it all the time.
There's an article today in New York Times about that, saying that more than 75% of doctors are now using these AI tools.
Yes. Okay, so 2 more research efforts. The first one is exploring Black adults' perspectives on the use of AI in health contexts. And so this goes to some community-based research and how we approach that. So as we've been talking about, AI is transforming healthcare. Yet as this AI transformation is happening, it's really crucial that we explore what the introduction of these tools might mean for people who are already experiencing poor health outcomes or poor treatments within a healthcare system. And so our work has focused on racial disparities within the United States, where Black adults have experienced long and standing injustices within the healthcare system, including higher rates of mortality, poor health in other racial groups, caused in large part by healthcare system failures and discrimination. For example, Black communities are more likely than other racial groups to have providers misdiagnose them. And researchers in HCI and related fields have increasingly examined the implications of AI in healthcare. And prior work has really demonstrated that to create more racially equitable health AI tools in futures, we have to invite and we have to act upon racially minoritized groups' perspectives on the present and the future of health AI. And yet research has rarely included Black communities in such participatory health AI efforts. So to begin addressing this gap, we sought to explore the research question, what perspectives do Black adults have on health AI and its ability to support health and racial health equity? And by racial health equity, we mean ensuring all racial groups have a fair and just opportunity to be healthy and eliminating the factors that contribute to racial disparities in health. And so our study consisted of a baseline survey followed by a 3-part workshop series. And the survey included questions from established national survey measures. It assessed attitudes towards health equity and health AI. And our survey data was really used to spur dialogue amongst and within our workshops and help contextualize our participants' perspectives by understanding how their outlook compared to a broader population. And the workshops focused on exploring participants' perspectives on the use of AI in various health contexts and for addressing health inequities in communities. So we had 18 Black adults from southeastern United States. They ranged in age, gender, and their prior use of AI. And our findings really speak to the varied perspectives that participants had regarding health AI, which was really rooted in a desire for health equity. So to begin with, our participants felt strongly that the issues of bias and equity are essential areas for focus of health and medicine. And they did so much more so than the national sample reported. So when we asked how much of a problem is bias and unfair treatment in health or medicine based on a patient's race or ethnicity, 83% reported that this is a major problem, and that's compared to 35% nationally. And 100% of our participants strongly agreed that advancing health equity should be a central value in society. Specifically, all of our participants said that our society needs to do more to make sure everyone has a fair and just opportunity to be healthy, compared to just 41% nationally. And our findings speak to the participants' attitudes regarding health, regarding AI's ability to go just beyond advancing health to also advancing health equity. And our participants expected that AI would make things better, and they did so at higher rates than previous national research had shown. So the other interesting thing, though, is the extent of their optimism varied depending upon the context. So most participants in our study believe that AI would improve the fairness of health treatments for patients across all races and ethnicities, whereas the national sample is more inclined to believe that AI wouldn't make a difference in this regard. But at the same time, nearly a third of our participants felt that AI would not make much of a difference or even cause further racial disparities. And so these findings really begin to convey the mix of health AI optimism and concern held amongst our participants. And people in our study were even more divided about whether AI would make the quality of healthcare better or worse for Black people in America, though they were more optimistic than the general population. And so when we held our focus groups, our findings really shed light on these nuanced perspectives that our participants held regarding the opportunities and the limitations of AI for countering structural barriers. For example, several participants described personal experiences they had receiving ineffective care. Multiple participants detailed, physical suffering that they endured while they waited for providers to believe that they were in pain and then address their needs. For example, P14 described how doctors dismissed and really ignored his expressions of excruciating pain for hours. It was only when they received medical imaging that they were like, oh, okay, they believed that he was in pain and they gave him pain medication he critically needed. Participants also describe in detail how they see medical biases negatively impacting their communities. For example, participant 8 described, prejudice that she as a Black woman faced in the healthcare system compared to her white counterparts. These biases that can lead providers to presume that she has a substance abuse problem or disbelieving that she has an injury or an actual ailment. And indeed, extensive prior work has documented the prejudices and the biases that Black communities disproportionately experience in the US healthcare system. And so when we're considering these structural barriers, the disproportionate experience of racial biases and ineffective care in Black communities, our participants expressed optimism that health AI might help address some of these inequities. For example, participants discussed the idea of AI second opinions, where AI could check to make sure that the provider did what they were supposed to do, conveying that those in their community may fare better when AI oversees doctors' decisions to make sure that the clinicians are actually providing the care. And while discussions of AI's ethical integration into healthcare often emphasizes provider oversight of AI, our participants really flip this model around. considering the value of AI overseeing a provider in what they considered an untrustworthy healthcare system. And so at the same time, participants discussed how, even an ethical AI system requires that healthcare providers act in ways that are morally just. And yet some participants felt that healthcare providers can't be relied upon to act equitably. So participant number 5 here describes how in a medication prescribing context, even if the AI recommends the best medication that might work for this patient, ultimately it's the medical provider who has to make the decision to prescribe the medicine. And this participant distrusted that those provider decisions would be consistently equitable. She said, that's when we're expecting people to be human, but a lot of times they don't act in such a way. So together, our participants really conveyed how, despite their optimism for health AI's potential, there were some fundamental concerns about its ability to reduce inequities given the persistent failings that they had witnessed, as individuals and within institutions in the healthcare system. So, yeah.
Was there any thread in here of people being worried that an AI trained by a system that has these inequities built in
Yes.
would simply persist those same inequities?
Yes.
Okay.
Yes, definitely. The participants in the study recognized that very much. As it all depends on how the training takes place and where it goes in. And they were not, didn't have their eyes closed to that possibility for sure.
That was sort of related, Paula. Do you think that were they concerned of, or do you think that there was an interaction effect of like the pairing between the practitioner and the patient's ethnicity? So like if I'm put in a scenario where my doctor is the same ethnicity as me, my trust evaluations may be very different if that's the context than if it's not.
Yes, that definitely came up in our workshops, and there has also been prior research that has discussed the racial concordance and trust amongst providers and patients too. So our participants really viewed AI's potential for advancing health equity with this idea that health AI could kind of serve as a form of armor, like a shield that minoritized communities could use to protect themselves from pervasive healthcare biases that disproportionately harm Black communities. And this idea of AI as a form of protection really differs from common visions of health AI, which really reflect values like precision, optimization, and cost reduction. And in contrast, by framing AI through this lens of protection from healthcare harms, our participants discussed AI as presenting new opportunities for Black communities to access fairer treatments or potentially more accurate diagnoses through things like AI-driven second opinions. Our idea here in this paper is that as we explore future work, we really should examine how health AI tools can be designed to activate and advance community-based power that have the ability to protect themselves from systemic harm. So that was a very deep paper, and definitely encourage you to check that out. This was from CHI this past year. Yes.
So you talked about focus groups, and there's a history and beliefs about focus groups. Were people in the same room and seeing how other people felt about it, or during the focus group? And obviously, the history of that is that often when one person is a strong leader, then everybody follows them. Did you see any of that kind of behavior, or did you feel like it was pretty even? How did you control that, or how do you feel like people should control that in focus group kind of work?
It's a great question. So we had 18 participants in our study. It was a 3-part workshop series. And so they came back for a very long workshop, 3 weeks in a row. And there were around 5 to 6 participants per group. And we held 3 versions of each group so that people could schedule and come when it worked for them. So they weren't always with the same people each 3 weeks. A lot of times they were, but oftentimes there was some differences. One of the things that we did in this study, so I mentioned we had a baseline survey and I showed some of the survey results of their perceptions of health AI and where they believed it could go, and where they believed it could work or where it couldn't. And what we did in the focus groups is that we showed the results from the entire participants' survey answers and on the screen in order to spur discussion. And so that allowed them to see, oh, wow, I see 3 people thought that and like 5 people thought that. And I thought everyone would have thought this other thing. And it really evoked much richer discussions, and allowed us to dive in with things that were unexpected to them, rather than just going with the topics that we had, by kind of showing the data that they themselves, as participants, had filled out. That really sparked a lot of our ability to not lean into dominant players.
Question. Do you think if this research was conducted via online or virtual space, would the result be different? And if it was conducted by someone, Black African American as well, would that be a little more different? Will they like the not patients, but the participants, will they feel a little more comfortable talking about certain things that they understand?
Yeah, it's a great question. And so this was conducted in person, and it was facilitated with 2 of my collaborators, Andrea and Christina, who are Black. And I was remote. And I think that had, definitely a big impact on people's comfort level and ability to be free with their community and discuss these harms and be much more open. I can't say how it would have turned out differently if it was conducted online, but all of these workshops were conducted in person.
The other thing was Ted's question is, it sounds like people were grounding their comments in their actual experiences, their lived experience.
These were lived experiences, yes.
So it's not, so attitudes are quite different from lived experience.
For sure, for sure.
I'm curious if the insights from the study was communicated with different stakeholders, like product teams, engineering teams, model builders, and how they received it, if you can speak to that, and whether it led to any outcomes in terms of extending community-based participatory research for evaluations, or like continuing and closing the loop along that, if you can speak to it at all.
I think actually our last case study is going to speak to that very well. So I will move on to the last one. Okay, the last project I'm going to talk about is called Elevate Black Voices. This was research that was led by Courtney Heldred. And there is also a paper in Frontiers that you can check out, and a couple of more that are in review right now. So hopefully more that you can check out. Okay, so this research has to do with automatic speech recognition systems. So we have all been giving commands to our phones and our smart speakers, and we know how helpful it is when these interactions go right. And we know how incredibly frustrating it is when these interactions go wrong. So despite the widespread adoption of ASR, automatic speech recognition systems, these systems disproportionately result in error rates for speakers who diverge from mainstream American English. Specifically African American English speakers, they encounter a high frequency of voice misrecognition. And this is mostly attributed to the absence of data in the data sets used to train large language models. So to better understand the experiences, though, Courtney ran a diary study with 50 Black participants from across the United States, asking them to really capture their experiences using these ASR systems and voice technology. And this participant really highlights how, it just feels really bad. I have thousands of dollars of devices that do not recognize me. And additional research has also kind of corroborated this finding. So this graph is from a paper in the Proceedings of the National Academy of Sciences, which show that Black speakers experience almost twice as many error rates compared to white speakers. This is 2021. And Courtney also published a paper in Frontiers really highlighting that this experience leads people to feel othered by voice technology. It really reinforces existing disparities, feelings of exclusion. And as a result, people often are forced to change the way they speak. This is called linguistic accommodation or code switching, and at higher rates than other speakers. And so there are several challenges when it comes to improving Google's products that current in-product data doesn't get us there. The first thing is that we don't have enough natural speech. People are all changing the way they speak in order to be understood by the system. And so you're getting unaccommodated speech. So that's a problem. And even where it is available, AAV data, it's really difficult to leverage. Self-ID is very delicate. User profiling is excluded. There are the absence of comparable data sets. Also, transcriptions of AAV data are also very, very errorful, and they're less valuable than for model training. So this effort really called for new methods of data collection in order to close that loop and improve the products. And so Project Elevate Black Voices, which is kind of a first of its kind collaboration between multiple teams at Google and HBCU. So these are historically Black colleges and universities, in particular Howard University. And so the goal was really to reduce racial disparities in these automatic speech recognition systems. And for the research, it was that a new data set needed to be collected, but it wasn't that, okay, we're just going to go collect a new data set, check, done, we can improve our products. It was about how they collected that data so that it wasn't extractive. And the priorities were really around creating frameworks for responsible data collection and then applying those best practices. And the challenge that you had is that you need to collect high quality speech data and it needs to be unaccommodated. So how do you do that? Normally when you're doing, I don't know if you've ever participated in speech training, but you're given a script and it's like read a bunch of strings and they ensure that they have all the coverage that they need and you can create a voice model that way. That's not going to work for something like this because you're going to get accommodated speech and you need unaccommodated speech. So how do you do that? So they did this through a community-centered approach together with Howard, and they worked with HBCUs to do a bunch of snowball sampling to engage with communities across the United States to also account for regional dialect and different vernacular. And lastly, the most important thing was that for this effort, the community owns the data, not Google. So Howard University is the steward of this data, owns the data set. It's open source. There's over 600 hours now collected and available. And folks who are interested in improving this and care about this research topic can get access to this data. So the real takeaway is, and generally for this project and many of the projects we've talked about, is that, inclusion is not the default setting. If you're going to build a product, if you're going to train an AI model, oftentimes you're going to be leaning on the easiest, cheapest, fastest route, and that's going to lead you to the data that's most abundant or most convenient. So this is how we can often inadvertently bake systemic biases and historical inequities kind of directly into these really advanced technologies. So if we're not really intentional about sourcing the data, if we're not proactive about testing with marginalized communities, our AI systems will just kind of magnify this exclusion that already exists in society. So investing in this type of research is not like a nice to have or like a final step that we bolt on. It's really a foundational principle for the innovation that we do and a priority for Google research. So that was my last effort. I will just say thank you. Yes, you had a question.
So you said it can be hard to collect the data in a natural way because usually people would just handle them over some script to let them read it. So I was wondering, in your study, how did you collect data in a like more natural way? Did you lead them to talk in conversations or to, I don't know, like free speech? How did that work?
Yeah, so it was a mix of those things. So it was not scripted speech, but Courtney and the team worked with Howard to design some prompts that people could take where it's like, answer this question and answer it naturally. And so the design of those prompts is a really interesting research question and design problem in and of itself. And that took a long time. There's a paper under review for that. So hopefully you can read more details about it soon. But essentially you don't want to have prompts that cause people to go down, relive traumas. That would be bad and not a good experience. But you do want these prompts to be open enough so that they're going to be speaking naturally. And they're also can go in so many different directions so that we handle the coverage problem by getting just enough collected data and getting it enough from enough people across the United States. So really relied on that community approach of snowball sampling from across HBCUs and family and friends, and that stewardship and connection to the project really built trust as well, knowing that it was going to be the community who owned the project and not Google who owned the project, all sorts of things that go in the design. It's not just about the instructions given to collect that data, and it's not these strings, but like the whole system around the project.
Thank you.
Quick question. I assume there's thousands of recorded interviews, conversations, like publicly available.
Mm-hmm.
So rather than seeking to those, I was wondering why it was a community effort, as you described.
Yeah, actually, the team found that they did not have public enough data set to improve the models, because they would have used that data to improve the models if they could have, but there was not simply enough.
A lot of the public stuff like that, labels, you don't actually know what's good. It's
If you go to, I don't know anything about it, so common sense I'm using.
Yeah.
If you go to YouTube, there's hundreds of interviews with Black.
Well, you don't know where the person is from, what the community is.
I think you may know where the person is from because you know their
They're
background.
Detroit, but they're actually from Louisiana. They're interviewed in Detroit, but they're actually from Louisiana.
Right.
It's the identification problem, so you don't have good labels with data, so you can't trust it. That's the problem.
So you don't know the person in YouTube?
Okay. Oh, you have a name, you have whatever the person put on there, be completely wrong.
And the region's very important because you have these different ISO classes.
But we're not talking.
It's just unreliable data,
Mhm.
and that's not useful for training.
But then in that case, this is also extremely biased, right? Because it's one local area. I mean, it defeats what you're saying.
No, you just have, this is your talk.
Damn. That's very it was across actually many different regions. So 600 hours. I don't remember how many different people. I think it was on the order of 20, 30 states, many different regions.
Yeah, I was surprised that 600 hours was enough.
Mm-hmm.
Can I add on to this question? And that is, I know of a PhD piece of work where in California, this thesis showed that there was different dialects 15, 20, 30 miles away from each other. And they were very distinct languages in different cities, towns. And then you think of, London, which we know has all these different dialects everywhere. And we know of, famously Boston used to. I think it's evening out now. But, do you guys have suggestions? He had some suggestions for how to label data or not label data, sanitize, or how do we, as we're going forward, and dialects are always changing, how would we suggest creating great systems?
One of the things for the labeling of the transcription of these hours was that it was done by a Black-owned transcription service who you could trust to actually transcribe the data in the way that it was being interpreted. That was a massive problem with how the training was just not able to take place before. And so that's one element, that it's not just the collection of the data and then how it's labeled. If you don't have the community doing the labeling of the data, you're going to get really weird things that happen.
The Blacks aren't even the biggest minority in this country either. So we have a lot more to work with than just that.
For sure. There was an additional paper at a CHI workshop this year done by someone in Google Research, which looked at Aboriginals in Australia and how they also have to, use their white voice in order to interact with these things. And so it is a very common issue where there are problems with speech recognition across if you have an accent, all sorts of various problems. So.
Good question. Finally, Google have amazing research and all the stuff, but this, like when you say go back to research or read a paper, that's more like from academic researcher perspective who have the time and interest in reading 200 or 20 pages. But how Google's approaching this, the results of this research that you guys conducted in translating into easy and understandable content to the general public, the masses, like, because again, I am applied anthropologist. I specialize in AI and all that, and I understand the academic side and apply it. But general audience, when they go research, they're not going to understand. So how is Google approaching that specific way of, because this is amazing research, but again, we have to be honest, nobody has the time to be reading that unless.
What are you talking about? I would certainly help you go read the research, and that is understandable. But no, you're absolutely right. That is very important to translate these findings to the public. And so one very practical thing that I do, that other researchers at Google do, is to write a blog post about it. And these have to be very consumable by the general public. And that can be really hard to do for super complicated topics. But all of these things can be written about and described in a way that the general population can understand.
Yes, it's very important because other people can read about it, like general public, and they decide that they want to contribute more, and that helps Google to either further research on whatever they're exploring.
Another thing that we do is give local talks. And so like this, but also interviews. So Courtney has done many interviews with news media. She's traveled to universities to give talks about the work in classrooms and other locations. And so a lot of it is just doing the work to share the results.
We have a couple questions over here. First term, and then
I'm just gonna jump in here just to be explicitly self-referential. This whole thing is streamed on YouTube.
Right.
I guess it's sort of a question, but back to your research project on AI and dermatology, one thing that I observed in my own personal life, being a daughter of immigrants, I know that it's a pattern. I don't know, I haven't done research on it, but I've observed this pattern that people from an immigrant background, they're afraid to go to actual clinicians when they have an issue, whether it's skin related or anything else. So I thought your project was really helpful in breaking through, getting people to have access to medical care more. Yeah.
Thank you. Yeah. I mean, access to care is a problem even within the United States, and is also a huge problem globally. There are many places that if you are pregnant, you're not getting an ultrasound, you're not going to get preventative care. Like it is very pervasive, and there are lots of ways in which technology can help. It's not the entire solution, but there are small things that can be done in order to kind of help screen and determine like you do need care, or no, you're fine. So that is something that I think technology can play a role in, where there are these gaps And oftentimes we think of these gaps as really extreme, like there's no doctor within 100 miles, but they also apply in various ways within the US healthcare system.
Do people use the dermatology scanning tool for like more sensitive skin issues that are like, I don't know, maybe they're ashamed of? Like, have you looked into that? Are they more comfortable doing the Google Lens and the AI tool then?
I have not talked to anyone who has done this, but Google gets billions of skin queries every year.
Okay.
So yes, you can imagine, yes.
A question here, and then she has the next one, and then you.
Yes, sort of a follow-up to some of the previous comments. I'm wondering about the 600 hours and just how far that gets you. Did you notice when that, like, were these people all pre-screened for having like a very standard African American English, or did you notice, oh, there's some sub dialects here, we should make a different model on those things? Was it just one model on the whole group? And
Yeah.
generally, is 600 hours enough, or do you think that like there's some bigger target to get up to like parity with?
Yeah, it's a good question. So I am not part of the engineering team that is doing the model improvement, so I honestly can't answer the question. So yeah, I can't answer it. I'm sorry.
But I can tell you that there's a lot of work to get that number way down.
Sure, yeah,
Yes.
I mean, they
want to do it with 20 hours.
Right.
Yeah, that makes a lot of sense. I mean,
For obvious reasons.
yeah. But you would want to make sure, but that makes it even more important that you have the people that you are in the samples that you're selecting are representative, right?
Right.
Yeah.
You had a question?
Yeah, for the Black voice subject, I was wondering, like, have you ever taken a look at if there is any age gap or generation gap among the the participants? Because yeah, because I'm from China, and in China, so like the generation of my grandparents, they don't speak Mandarin at all. They just speak their local dialects. From my parents' generation, they can speak both the dialect and the Mandarin, but also with some accent. For my generation, I cannot, I'm ashamed of it, but I cannot speak my dialect perfectly. My mother tongue is Mandarin and such. So I was wondering if there's such like a similar trend for Black voices in the US.
Yes, and this is true across many different groups as well. I think like in one of the participants in the study, she's like, oh, it depends on the context. Like, oh, if I'm asking it about beats or dance hall, I'm going to use that accent. And so there's all these accommodations too that people make depending upon what, not only like what the topic is, but even if they're talking like to, I know when I talk to my mom, my Minnesota accent comes out. But and she mentioned in particular, she's like, my husband's from Nigeria, forget about it. It never recognizes him. And so also it's not only generational comes into play too, in just how people's accents are formed, but then even their interaction with the people and then the technologies in the mix, then you get all sorts of weird things happening.
There was a question here.
Yes. I was thinking about the previous work around health AI and how it can be used as an armor.
Yeah.
There were actually across all of the projects, there were so many parallel threads that I was associating with my dissertation research. So one of the things that came up, so I studied urban accessibility and collecting data at scale and using that data for advocacy, urban policymaking, daily living decisions. So during one of my studies, I looked at interviewed a bunch of advocacy organizations who've used, because urban accessibility data is also extremely hard to collect, especially at city scale level. So they were very, very excited, just like participants from your studies as well, of the power that it gives them to push for changes, social changes, physical infrastructure changes. But I think there is so data-driven advocacy versus AI-driven advocacy. There is a trust issue that is, I've been sitting with it because people don't yet trust AI fully in that way. They trust, I mean, there are people who don't trust data too, but there's more trust in data than AI as I see it currently. So I was wondering if what's like the next step? Or have you been looking into how you would go about studying that AI-driven advocacy? Because the trust can be a very complicated thing in that space.
Yeah, I think what's really interesting is that we do have enough people who have already started to use AI in that way for advocacy purposes, whether it's self-advocacy or their community or on the civic level. And so I do think that opportunity exists to understand how that's working even right now, because there are folks on the edge who are already who already do trust it and are using it, and you can see where it's working and where it's not. Yeah.
I kind of want to broaden out if we can. You have five case studies, and you do a kind of work. Looks like lots of mixed, a lot of ethnographic, a lot of asking things. And I want you to kind of think about what you have to say to researchers that are not in such a, maybe not in a country with 250,000 people, but are trying to do this kind of work. And what are some of the, things that you've learned are either great things to be thinking about or things not to be doing that are common across all of your research or you've learned in your environment, and maybe even also mention what things you might think wouldn't be applicable to other people's environments, if you have any things like that. Just to broaden it out if you can.
Yeah, I mean, I think one of the biggest takeaways that I've come across is, especially in the clinical space, like you're really in clinical spaces, these are very complicated. The systems being used by the parties in this space, whether it's clinicians or patients or tertiary users or administrators, are complex. And I know that sometimes the thought is like HCI work just can't be done in this space, or like the only work that I know I saw for a long time were things like almost architecture style studies, like, oh, if we move the nurse's station here, then that's going to allow for more things here. Like you could install some like motion sensors and then study it from afar. But actually it is feasible to do this type of experiential work, even in these settings. And the methods do need to flex a little bit. It's not the same as inviting people to a usability lab and you have this very structured setup and you're measuring things that way. When you're in a clinical environment, you have to flex a lot. But the core of the research still is the same. Observation is observation, whether you're doing it in a lab or whether you're doing it in a really busy clinic. And so I would just encourage, I hope that the industry will begin to do more of this work. And these things naturally require collaborations which are perfect for HCI. It's a naturally interdisciplinary research area. So the power comes from these really nice collaborations with clinicians, with health systems, with patients, with doctors, with researchers, all working together to kind of understand a problem in a space and design better solutions for it. And when that happens, you get better solutions and you get better experiences. My hope is just to show, it sounds really silly, it is feasible, but it is feasible. And I'm hoping that there can be more.
So a follow-up question is, can you tell us some stories or examples or take-homes about how, your work interacted with the engineering, the patients, the different players, and some surprises for them or for you in that interaction, and hopefully something positive, although there's always the other side.
Yeah, definitely. I mean, if we go back to the very first example, which was the diabetic retinopathy problem, these were AI engineers who'd worked very, very hard on the model that they built. They've done these evaluations. engineers really care that the thing that they built works in the world. And so when it doesn't, it can be really unnerving. And oftentimes there is really strong partnership with UXers, whether it's designers to work on maybe the solution to the problem is actually a design solution rather than an engineering solution, or maybe it's putting a drape over the person's head solution, and we get that through user research. Or maybe it is model improvements because we see all of a sudden a new type of camera being used and we hadn't accounted for that, and we can work together to understand it. And so, things always work better when everyone's involved and really invested in the research. And I've found engineers to care as much about the user experience as user experience people do. And so that's one example of a project where folks are naturally very invested in making sure that this system works, because it wasn't just that it was an AI that had great accuracy. It was that it had, it helped people get care that they needed or not. And that's why people were doing it at the end of the day.
And then another follow-up, and I don't want to dominate, but can you tell us an example of a road bump and some, cautionary tale that came up in any of these things? Because sometimes that's where we learn a lot.
I'm trying to think of what a good example might be.
There's resistance to putting drapes over your head, I'm sure.
Well, like I don't know that it was really resistance or a road bump, but the skin data set, naturally, that's really tricky. You're crowdsourcing, images of people's skin. You're inviting people to take pictures of their skin. All of that's really tricky. And so I think the designer on that project, Anna, who I mentioned, really understood that a lot. And there were lots of internal testing for like, is this, do these instructions help people feel, safer doing this, or worse, or better or not? And so the design iterations around that were not straightforward. If you're just, going around collecting pictures of people's skin, that feels really weird. So that was bumpier than your typical design requirements for, a button in Gmail or something like that. But all also like kind of bread and butter UX work with understanding the problem deeply, taking into these considerations and making sure you really know the problem space before you begin putting pencil to paper, so to speak.
A follow-up question.
Yes.
Did you have any issues with the hospital management or the insurance companies in particular? Because they seem to be always like they're overwatching, I'm just curious.
Yes. So for hospital management, I haven't encountered that before, from almost a resistance to like, you can't speak to my doctors. You can't understand them. They are my staff, and we can. So that's definitely, that exists. That challenge exists.
Granted, Google's name carries a lot of weight in terms of,
Yes, definitely. But even still, that doesn't, I didn't go to medical school, and so that they're like, you don't know, no, you're not getting near a physician. So it depends organization to organization about how really open people are to even trying to measure the experience. So that's why the work that Meredith did with Mile Bluff, I really, really loved, because it showed feasibility. And it's like, if you are open to this, it's really not that complicated. And it gets you so much valuable data about where your clinicians are struggling and where this technology that you're giving them is actually helping or not. So you can see, do you actually want to go now spend the time measuring errors that you saved, because maybe you should, or all of this very useful data. So I've definitely encountered challenges along the way, but also systems that are very open to that style of research.
No issues with insurance companies?
Actually worked with insurance companies, yeah.
So we've been asking you so many questions. You've been very, very patient with us. Good night, Dan. Good to see you. Just, is there any other questions, or we've exhausted it and we just need people to eat more cookies and talk among themselves maybe? What do you think? Is that enough, or do you have something you want to ask?
I'm intrigued by the notion of like linguistic drift, right? Like whatever the models are that are currently trained, right? Like we've talked about generational change, but Boston's changing. How are we? This is a giant question, I'm sure, but like, is there a temporal element, a dimension that you're thinking about in your work, let alone just like sort of the larger question of, modern English doesn't sound like Elizabethan English.
Yeah.
And does this sort of like lock in everyone's got to speak 2020 English, American English to their Alexas for the next decades?
It is a really good question. And it's really interesting too. It's not only in voice recognition systems, but also in writing. There's a lot of research around this when it comes to AI generated writing and how that's changing the way other people are writing. And is that going to really hamper creative thinking and all of these skills that come into play with writing? So it's many bigger questions around language and the use of these technologies, whether it's input or output.
There's a crazy band out there that's like specifically creating music that is not typical in order to like stand out from not being mistaken for AI. Like crazy changing time signatures and syncopations and yeah.
So with that, I think that we should probably close the meeting, and people are welcome to spend a few more minutes getting to know each other. It's great to have everybody here. Thank you. Consider joining BayCHI. It's a yearly $20 that pays for the IT and the food and other expenses.
It's time to raise the price with all the inflation, don't you think?
I think that's true. Yeah, that's right. You could buy one cookie for $20, I think.
That's right.
But the main thing is thank you for your contributions, everyone that has joined.